palliative care is not just about dying. Actually, palliative care is all about living, and living as well as possible in whatever time we have left.
Greetings and welcome to this episode of the Kernel Network podcast. Today I'm very honored to have the opportunity to speak with Dr. Pereira, who is a palliative care physician, professor, and director of the Division of Palliative Care in Family Medicine at McMaster University in Hamilton, Ontario. Dr. Pereira is also the co-founder and scientific officer of Pallium, an organization dedicated to building professional and community capacity to improve the quality and accessibility of palliative care in Canada. When I think about palliative care and end-of-life care more generally, in Canada especially, I can't really think of anybody who's got more experience or better insight currently active in this area than Dr. Pereira. So it's really a great pleasure to have you with us today. And so I'd like to talk about a few things and just opening up with a general question. As I've been saying, you have a lot of experience in palliative care, and not only in Canada, but around the world. So could you tell us a little bit about how you got involved in this work and where you've worked nationally and internationally?
Sure. Thanks very much, Andrew, for having me, and thanks for those very kind words in the introduction. So how did I first get into palliative care? I was working as a family physician in a small rural community in Manitoba. And on one particular day, a patient came to see me. And interestingly, it was a patient that was not of my practice. I was, in fact, the third physician he had come to seeking help. He came in with his wife, sat down, and I vividly remember this encounter because it changed my career and it got me into palliative care. He sat down and told me that he knew that he was dying of advanced colon cancer. And he knew that he had only a few months to live, but he said he was experiencing excruciating pain and just could not live like that. And so he had come to me to ask for help in relieving the pain. His name was George, and I use his name because I've been given permission to use his name. And I remember thinking to myself at that moment, my goodness, I had no idea what to do because I'd had no training in palliative care. In fact, at that time, I didn't even know the word palliative. And so I asked him what he was on, and he said he was on morphine. And today I know it was a minute, ineffective dose. But at the time I said to him, I'm sorry, George, I cannot increase the dose further because he'll become addicted. And I'm afraid I don't know what more to do. And George got up, took his wife by the hand. They both started crying. He got to the door, turned around as he was opening the door to leave my office, and he said to me, I hope people like you, meaning healthcare professionals, can one day look after people like me. And so he left the room, and I was left in shock. I was left feeling very embarrassed for myself as a professional being able to help, embarrassed for my profession not being able to help. And so I remember walking out of my office and going to a small coffee room we had in this small little clinic in a small rural community. And there was a nurse there, a very good friend. And I told her the story about what had just transpired. And the next day on my desk was the Canadian Medical Association Journal, and it was open to a page that advertised a course on palliative care. And I only recognized that it was what I needed when I saw the subtitle, which was Caring for Patients who are Terminally Ill. And so it was a course at McMaster. So I flew down to get to participate in the course, and it changed my career. I flew back after 5 days, called up George, and I said, George, I'm so sorry. I made a mistake. I didn't know the training, but I've just received some training. Can you please give me a second chance? Which he did. And I learned that with a little bit of training, one can make such a difference in people's lives. He died very comfortably and died in his community in southwestern Manitoba. And that experience taught me that it's something that I really want to do. And after that, I went to look for training, and I ended up doing a clinical research fellowship at the University of Alberta in Edmonton. And so that was the start of my career, and that was back in 1995. Then since then, so I worked there for about 5 years in Edmonton, and then got recruited to go to Calgary to open up the first palliative care unit in Calgary, and that was about 2001. And then in 2006, I was recruited to Switzerland to be the first professor of palliative care in Switzerland, specifically in Lausanne, and also with some work in Geneva. I did that for almost 3 years, and then got recruited back to Canada and worked in Ottawa for 10 years, and am now in Hamilton. But during the years, I've done a lot of work with colleagues from different countries. I've been part of the African Palliative Care Association. As you can hear by my accent, I was actually born and raised in South Africa. So I've tried to give back as much as I can over the years, and I co-founded the African Palliative Care Association. My family are from Portugal, and so over the years I've also tried to give back to a land of my roots as well. So I continue teaching there, and I've done a lot of work there over the years.
Wow, thank you so much for sharing that. You've got so much experience. It's really a global perspective, and I'm really happy that you can share from that perspective. I wonder if you could summarize for us some of the main work that you've done in some different areas. I'm thinking of 4 areas in particular: clinical, research-related, education, and service development. If you just say a few things about some of the main things that you've done in those areas.
All those 4 areas have been very intertwined, and I've been very fortunate to be able to try to bring all those together. So in my clinical work, I guess my first foray into it happened soon after I finished my palliative care specialized training in Edmonton, and that I was asked to join the brand new regional palliative care community consultation team in Edmonton. So this is in 1996. They've just done a remarkable thing in Edmonton. They had invested significant dollars. Even at the time, Alberta at the time was a have-not province, but they were wise enough and had the vision enough to invest in palliative care services, and that included opening up new hospices. And to save costs, they open up hospices in existing nursing homes. The hospices were staffed by hospice staff at the hospice level, hospice training, and the space was converted to be more homey and much more comfortable for patients and families. They invested in teams to provide consultation support in the community and in the hospitals. And actually a few years later, about 7-8 years later, they actually did a big study and showed that as a result of their investments, not only did they improve care, but they've also actually saved the healthcare system millions of dollars in the process. But what I learned with that team, so we were 4 doctors and 4 nurses, and our job was to go around and support family doctors. And the whole concept was, the analogy of teach someone to fish and they'll have fish for a lifetime. Well, our role was help the family doctors, help the home care nurses, and in some of the smaller community hospitals, help the professionals working in those hospitals to provide really good core palliative care to their patients. And so thereby building up system capacity so that it wasn't only reliant on a small group of doctors and nurses. And that's important because that lesson has driven a lot of what I've done, also in education and also in health services. I can come back to that. I learned the important collaboration that needs to exist between family physicians and home care nurses and small groups of palliative care specialists. It can't all be the role of palliative care specialists to provide all the palliative care needs of a population. And so we need to work very closely. And I'll extend that not just to family physicians, but also to healthcare professionals, doctors, nurses, social workers working in cancer care, caring for patients with advanced kidney disease, advanced lung disease, advanced heart diseases, amongst others. My work in Calgary in establishing the first palliative care unit there for me was an eye-opener, in that I had worked for some years on the palliative care unit in Edmonton. It's a whole different thing when you're setting it up from the beginning. And what I learned was that there is a temptation in hospitals that have palliative care units for those different units, the medical units, the surgical units, to emergency department, to think of the palliative care unit as a place to send the patients to die. And so we really had to put a lot of criteria in place and say, no, this is almost like an intensive care unit, as it were, for palliative care. We weren't doing things like machines and life support, but we did have a fantastic, well-trained team to care for patients with the most complex pain and complex symptoms and psychosocial needs. So it was specifically for patients with the most complex needs. In Switzerland, when I went to work there, what I learned was that in the canton of Vaud, so the equivalent here would be a province, but the canton of Vaud and the canton of Geneva had 5 community palliative care teams and some teams in hospitals. And what we soon realized was that because there was no standardized specialist palliative care training in Switzerland, you had these different teams with different competencies and skill sets. So one team could do certain thing like use some of the sophisticated opioids, another team could not do that. So a lot of our work was around first identifying what are the competencies that are needed at that level, and in fact at all levels, but at specialist levels, so that we can then bring everyone up to speed. Now that's very important, because the analogy I use is, imagine if you get into an airliner and the pilot has been trained only to fly a small light Cessna aircraft. I think one would be nervous. And so I think it's important that people have to have the right competencies for the job at hand, for their role. And I see in some provinces, and even here in Ontario, that there sometimes are physicians and nurses who open up a practice doing palliative care as a specialist, but without that training, without the advanced training. So I think that there's some attention that needs to be paid to this. When I moved into Ottawa, the clinical work was interesting in that at the time, we had in Ontario these entities called LHINs, Local Health Integration Networks. There are 14 of them. They've just been disbanded about a year or two ago. Which leaves me a bit worried as to who's going to be overseeing all of this. But the LHINs were tasked by the health ministry and by the government to provide and organize services locally. But across the 14 LHINs, with some exceptions, it was generally poorly coordinated in terms of palliative care organization. And so a lot of the work we did in Ottawa was to establish the first regional palliative care program, which said, let's try and organize this from a systems perspective. And the analogy here I use is a car. If you go to a car dealership, you're not going to say, I'd like that car. But I don't need all 4 wheels. I just need one fantastic wheel. Don't worry about the brakes and don't worry about the transmission, etc. I just want this one fantastic wheel. Well, it's not going to work, right? Because it functions as a system, as a whole. Patients experience different needs as they go through the illness trajectory, whether it be cancer, heart disease, lung disease, etc. And across that journey, they're going to need different services, whether it be at home or in the family physician clinic or in the heart clinic, dialysis clinic, cancer clinic, or in the hospital if they get hospitalized. And so it's important that there are all these services in place, the right amount by the right people. So if you've got 1 or 2 or 3 of those pieces missing, then patients fall through the cracks and you see problems occurring such as too many patients having to be cared for in hospitals at the end of life. About 40 to 50% of people across Canada who are dying of advanced diseases end up dying in hospitals. And we can do much better than that. And Edmonton program actually have shown that we can do better than that. So what I learned in that was the importance of systems thinking and having all the different pieces of the puzzle and all the different stakeholders working together. In my work here, at McMaster, I've been doing most of my work at Brampton and William Osler Brampton Hospital. And what's been fantastic there is the multiculturalism of the hospital and learning to work with families, patients and families from many different cultures, different religions, different thinking. I've really enjoyed that work enormously.
Dr. Pereira, could you say a little bit more for us about your work in the areas of education and service development specifically?
There was a study that was published fairly recently by a group of colleagues across Canada that found that for example, in medical school, almost all the schools do provide, so of the 17 schools, there is some palliative care education in most of them, with the exception of 2, there's no palliative care education whatsoever. But in almost all of them, it's optional. There are only 2 where it is compulsory. And in the ones that are optional, the minority of the students tend to go and study and learn about palliative care. So many medical students are finishing or graduating without these skills. And then what happens in practice is now they go into residency programs, and residency programs, the same study showed that, for example, in family medicine residency training, now family medicine is one of those specialty areas where physicians care for patients with advanced diseases, heart diseases, lung diseases, cancer, etc. It's variable across the country, but in some schools, only about 30-40% of the family medicine residents train about palliative care. In other schools, it's a bit higher, 60-70%, but room for improvement. And similar gaps are found in other specialty areas. And then you get to, once you finish the residency training, then you're in practice. There was a fascinating study done by the Commonwealth Fund of 10 or 11 countries of the OECD countries, so the wealthier countries, as it were. And in that study, they asked family physicians if they were comfortable providing different types of services, care of the elderly, etc. And one of them was palliative care. Only 42% of Canadian family practices said they were comfortable and prepared to provide palliative care. And that was very low compared to countries such as the United Kingdom and Netherlands, where it was in the order of about 80% and 90%. So education is extremely important, and probably the largest piece of work that I've done in Canada since 2000 was the Pallium Canada program. So inspired by what George said, which was, I hope doctors like you can look after people like me, I co-founded Pallium Canada, which is a non-profit organization, and we did that in 2000 when I was still in Edmonton and in Calgary. And the whole mission of Pallium Canada is to train up as many healthcare professionals across all settings of care, so that's community and home, hospitals, long-term care, paramedics, on these core competencies to allow them to provide palliative care and to address those gaps that I've just described. So I'm very proud of that work. It's spread across the whole country. We've trained over 40,000 healthcare professionals across the country. In some provinces, we've trained up most of the paramedics, for example. There are courses happening in long-term care homes. So very promising work, but we've only touching the tip of the iceberg in terms of training up all the healthcare professionals. What is palliative care? To let them understand that palliative care is not just about dying. Actually, palliative care is all about living, and living as well as possible in whatever time we have left if we have an advanced disease. So I'm looking forward to that moving across the country.
Mm-hmm. That's some great work. I wonder, in relation to my next question, how would you characterize the quality of the palliative care that we currently offer in Canada? And maybe you want to focus on Ontario. From some of the things that you're saying, I'm wondering if it has to do with education, but I don't want to prejudge the matter. So if you were to sort of characterize what the state of palliative care is currently like in Canada for the audience, that would be wonderful.
I think I would summarize it as Canada is a patchwork, and most regions have got something that is phenomenal and excellent. But almost all regions also have gaps. You might have a region that has a fantastic palliative care community team, but there are no hospices or insufficient hospices, or large communities with no palliative care units, or hospitals with very little in terms of palliative care resources, but strong community teams. So going back to the analogy of the car and making sure we have all the components, I think it's a patchwork across the country. And it's interesting, if you look at, we have been compared actually with some other countries. In 2015, The Economist and the Economist Intelligence Unit undertook this very large study to compare, I think it was 81 countries across the world in terms of how they're doing with respect to the quality of palliative and end-of-life care. And Canada overall ranked actually pretty good, up in, I think it was 10th place. But sort of in the middle of, if you look at all the different domains, it ends up being sort of middle of the pack amongst the wealthy countries. And again, very recently, there was an update study done by a different research group, and again found Canada to be in the middle of the pack of the wealthy countries. So up in the top overall over 80 countries, but middle of the pack with the wealthy countries. In Ontario, again, we've got, it's patchwork. I think there's been, importantly, attention placed on hospices and ensuring enough hospice beds, because the province really lacked and is still lacking in terms of the right number of hospice beds. But I think we shouldn't forget that there are other pieces of the system that also need to be put in place. And so there are hospitals still that have not invested in ensuring sufficient palliative care services, sufficient palliative care teams. We have challenges in the different medical schools. We're continually having to try and integrate more palliative care education. The nursing schools, there are some nursing schools that are integrating palliative care in their training, but many who are not. If we take seriously the research that shows palliative care should begin much earlier in the illness, not just in the last days or weeks of life. It should start at the beginning when the disease is found, and the disease is found to be progressive. And palliative care can be done alongside treatments to control the disease. So alongside chemotherapy, if it's cancer, radiotherapy, alongside treatments of the kidney disease or the lung disease. And by doing that, patients' care is optimized, their disease is being treated and controlled, and at the same time, there's attention to the person as a whole, the quality of life, to managing symptoms, managing psychological, social distress. So if we try and integrate that, it's impossible to expect all palliative care to be done by only a small group of palliative care specialists. And so it's extremely important to build up this core capacities across all specialty areas: family medicine, oncology, cardiology care, heart care, kidney care, dementia care, long-term care facilities, right across all care settings, across all specialty areas. And I think that in Ontario and in Canada, we haven't put enough attention to building the system that has got a strong primary palliative care basis, and it's palliative care provided by clinicians of all different professions and in different settings who are not palliative care specialists is often referred to as the palliative care approach. And we've got to stop thinking of palliative care only as this negative thing. We've got to stop thinking of palliative care as being only relevant in the last days or weeks of life, and bring it much earlier. By doing so, people can live better and also make better decisions about how they're going to spend the last days and weeks of their lives. As I said earlier, too many people are still dying in hospitals. How can we reduce them? It's not the best place to die, and it's not good for the system.
So if to use your analogy of the car, if you were to describe sort of the palliative care system in Ontario, how many wheels would it have? Would it be kind of going along on two wheels? Would it have three? I remember that Economist study that you mentioned, and I think I remember Canada being around the 10th place, but I think their score was only around 70% or something like that out of a possible 100. So that sort of suggests maybe almost three wheels. Do we have almost three wheels going, or?
Well, yeah, in that Economist study, where Canada really did poorly in, actually, ironically and surprisingly in a way, was in terms of public funding and in terms of funding of all the healthcare costs. and I think we came in only about 28th spot. So studies, for example, have shown that it costs about $25,000 to care for someone at the end of life in the last 6 months of life. And of that, about $7,000 or $8,000, and sometimes more, is through publicly funded. But the rest is out of pocket of the patients or families. And there are also a lot of unpaid costs. So family caregivers who have to give up work or jobs or other work opportunities in order to care for someone. And there's the big gap there. Even though we are a country that do provide a lot of support, there are a lot of gaps around it. If you look at Ontario, I almost want to say it's like a fleet of cars that look completely different. Some have got only one or two wheels. Very few, if any, have got four wheels and the engine and the whole piece put together. So you see at least 14 fleets of cars. So corresponding to what used to be these 14 local health networks. And even within those regions, you see enormous variability. So, for example, if you look at the area, the Durham-Oshawa region, there are big differences between the northeast towards Peterborough versus the southwest towards Scarborough. Some fantastic teams working really hard, often without the proper funding models that would allow them to do the work that is needed at hand. So, for example, in the hospital at Lakeridge, for example, as with many hospitals, including hospitals I work in Brampton, we have time and time again asked the government, please, can you provide us with a funding package, which is referred to as an alternative funding plan, a salary type of setup, instead of fee-for-service. So fee-for-service means you see a patient and then you bill only for the clinical work. There is no funding to support all the other important pieces, such as teaching others to fish, as it were, such as leading change, such as finding the different wheels and mounting the wheels, so the leadership and the health systems organization. And so the government has failed on that one, and not just this consecutive governments from all the different parties. So I think it's different. Many different cars that look very, very differently across the regions in the province, and even within those regions, you see different vehicles looking differently.
If you were to pinpoint one thing, and in some ways we've already got onto this, but if you were to pinpoint one thing that needs to change to improve our delivery of palliative care, what would be the most important factor? And I guess for this question, you could think if you're speaking to a government minister who had the authority to implement one particular thing, what would be the most important area, like single area, to ensure that palliative care is delivered in a high quality fashion across the country, or even just at the provincial level across the whole province?
Courageous and wise leadership. I think it's important that the government folks start thinking about what's best on the long term and not just what's best on the short term in terms of political advantages. Think about what investments are needed today to have long-term sustained impact in the future. And that requires, for example, the ability and the wisdom to say, you know what, actually, instead of saying to the palliative care teams that want to be set up that we have no funding, there's no funding. Actually, there is funding. There's a lot of funding in the system. In Ontario alone, it's been calculated that 10% of all healthcare costs in Ontario go into caring for patients in their last year of life. And we are talking about billions of dollars, so around 4.2, 4.5 billion dollars. The money is there, it just means of how it's allocated. And take the example of what they did in Ontario 25 years ago. Invest in some areas, and the same occurred actually in Catalonia in Spain. In the late 80s and early 90s, Catalonia also approached us from a systems perspective with courageous leadership and wisdom and said, we will take money, we will invest in it because we know that it's good for the society, it's good for patients, and we're going to be seeing lots of cost savings elsewhere. So that would be my main message: courageous leadership, and sit down with people who work in the front lines of care. We've got a lot of experience, and we can provide insights that may help advance things a lot. And let's celebrate the good things that we do have. We've got fantastic things. Let's spread and scale them. For example, the Pallium project, we do courses called LEAP. It's been profoundly frustrating for me going to federal government to look for funding for it, and also going to provincial governments, including Ontario, saying, look, here's a ready-made, proven program that can equip people with these core skills and thereby increase people's access to palliative care. Fund it, please. And it's frustrating the federal government when they say they're really only interested in new innovations, when actually it was an innovation 20 years ago. Help us spread and scale this instead of looking for new pilot projects and new things. So spread and scale the good things that we do have, and invest well, because it's good for patients and families and society, and it reduces costs as well.
Mm-hmm. Now, if we were to switch to another audience and to ask you a kind of a similar question, but now imagine you're talking to a student or an interested member of the public who believes in the importance of improving end-of-life care, and who has caught some of the vision that you shared, and that you that took hold of you in relation to your patient George, and just the importance of caring well for people at the end of life, people who are facing life-limiting illnesses. What would you say, what's a practical thing, or one or two practical things that someone like that who says, I want to help out here, I want to do something meaningful, I want to contribute somehow to improving the way that we take care of people, what would you suggest to them?
Sure. So if I'm speaking to students, I think what I'd say to them is, look, if you're a student in the healthcare professions, then ask yourself, form a group of like-minded students, and your voice is strong. Your voice is heard. If you go to your professors, if you go to the head of the departments and the faculty that you're in, and say, look, this is an area that we want to learn about because it's so important for society, then find out what is happening and advocate for the proper integration of this, so that when you graduate, you've got those skills. And it's not just for medical students and nursing students and social workers and therapists and pharmacists. I would say as well, in many of these schools on, public health schools and the health science schools, because that's where the future leaders, not only leaders in the healthcare system, clinicians, but in leadership, health system leadership, and in things like biomedical engineering, etc. They should also be thought about, why is this important and what a difference they can make. I think it's also important that they also do some self-reflection, and so start asking yourselves, most of the learners are quite young and early in their career. Have a conversation about what is important for you if you get diagnosed with a life-limiting illness. What's the most important thing for you if your parents or your grandparents or loved ones are diagnosed with life-limiting illnesses? What is it that you would want for yourself, and how can you care for your loved ones or close friends? Because serious illness affects all age groups. So how can you make a difference? There's a movement of compassionate communities. Perhaps start joining a compassionate community. I've got an example of a young high school student just up the street from where I live, who started a small compassionate community project, himself and a friend, and they're reaching out to frail elderly in our neighborhood to say, we'll help you. We'll take away your garbage and we'll come mow the lawn. Those are examples of mobilization, of student mobilization. In terms of the public, I think the one most important thing is, please inform yourself about what palliative care is, so that we can start destigmatizing this whole notion that palliative care is only about dying and is only about the end of life. Have conversations with your friends around the dinner table, around the barbecue, and say, you know what, I just learned something. All these years, we've been wrong about thinking about palliative care being only about death and dying. It's such a negative thing. It's actually a fantastic thing because it helps us live in whatever time we have left.
Excellent. Well, I think we're about at the end of our time. Dr. Pereira, I just would like to thank you so much. Is there anything that you feel like you would like to share that we didn't get onto with these questions, or any sort of final thought that you'd like to voice?
I think it's covered most of it. Most of the important ones. I'm sure I'll think of other things afterwards.
Yeah, I think we covered a lot too. I really appreciate you taking the time to do this, and for people who listen to the Kernel Network podcast, people are very interested in and passionate about how can we understand what's going on in terms of end-of-life care, how can we take steps to improve that, how can we improve our networks and connections with others who have similar interests. So being able to hear your voice has been very helpful.